So I gave a prior talk that focused on the steps and approach and algorithm to coronary bifurcation stenting. And I focused mainly on the provisional approach. I will focus in that talk on the two-stent strategy, mainly the crush type of techniques. So this is the important algorithm that we all should know. And basically, what bifurcation lesions qualify for two-stent strategy? When you're approaching a bifurcation, as I explained last time, realize that over 80% of bifurcations will qualify for the provisional strategy. You don't need really to engage in that two-stent strategy. We really think of the two-stent strategy in a specific subgroup. It has to be true bifurcation, meaning both the side branch and the main branch are involved. That's one. Two, it has to be a complex true bifurcation, meaning the side branch is not just involved 50%, but it's more than 70 to 90%. 70% in case of left circumflex, left main, 90% in other disease. And most importantly, the lesion has to be long in the side branch, over 10 millimeter. And you have to have other complex features, especially heavy burden in the side branch or in the main branch, heavy and long burden, plaque burden. That predicts a plaque shift and side branch occlusion, or bad angle, or calcium, okay? So you need that triple combination of bad things to qualify for two-stent strategy up front. What's the biggest downside of a two-stent strategy? If you want to pick one downside, is that you have to rewire the stented area twice in a lot of the techniques, or it's difficult rewiring even if it is once in the regular crush technique. So much so that I consider how difficult it is to recross each time I'm planning a two-stent strategy. This actually may avert me from doing two-stent if I think rewiring will be difficult. I actually avoid it if I think the wiring the side branch once will be difficult, much more if I will have to rewire it 2 more times or overall wire it 3 times. So including wire it through stent struts. So I take that into account. You absolutely have to rewire with this technique and do final kissing balloon inflations. So take that into account. In addition, several of the two-stent strategy, several of the trials of provisional versus two-stent strategies, included some lesions that were complex, like EBC2 trial, and they showed that provisional is an acceptable approach that achieves relatively equal outcomes. So for that reason, just know the limitation of when to go into two-stent strategy. Okay. This is again another table I showed last time that tells you which patients do qualify for two-stent strategy. What do we call true complex bifurcation? Size, length of the side branch disease, severity of the side branch disease. Another thing you will notice, left main qualifies for a two-stent strategy more readily than non-left main for a couple of reasons. One, the left circumflex is a larger vessel, usually with a larger territory. That's one. Two, it is easier to rewire in case of left main, and I will explain why. It's easier to rewire side branch when you're proximal, very close to your guide. You have more wire control. So those are 2 reasons why you more readily qualify for a two-stent strategy in left main than in non-left main. So what are the planned two-stent techniques? There are 3 major two-stent technique. One is the crush, which is subdivided into 2 types of crush. There's the single kiss traditional crush, which comes in multiple flavor. The most important one is the mini single kiss crush. Then you have the double kiss crush, DK crush. You have culotte, and you have the tap T-stent, TN protrusion, which I explained last time as a provisional strategy, as the most important provisional strategy. It can also be used as a planned two-stent strategy. So those are the 3 most important techniques. Some operators may favor one technique over the other. I will tell you that any of those 3 techniques is okay. You don't have, it's not mandatory for you to do crush or DK crush. Each one of those three techniques will find support in at least one modern trial of two-stent strategy versus provisional. Those are the modern trials of two-stent versus provisional stenting. And you can see that, a lot of them, Nordic, EBC2, EBC left main, they predominantly used Culotte technique. If you look at some other ones, Excel analysis, Excel, the study of left main stent versus cabbage, even when the operator went for a planned two-stent strategy, tap was the most common technique, 50%. Second was Culotte. Third was crush. So all I'm trying to say is that most trials did not focus on the crush. So the point I'm trying to make is that Culotte and tap are acceptable two-stent strategy. DK crush has a great support as well. And maybe one of the reasons I like it and a lot of operators like a crush and DK crush is that specifically the two trials that show the benefit of two-stent over provisional strategy use DK crush as your two-stent strategy. So those are the two trials that show two-stent is superior to provisional. I still don't think DK crush is what caused those trials to be superior to provisional. It's the fact that they selected complex true bifurcation that made two-stent strategy a legitimate strategy in that case. That said, DK crush was used, and that's one of the reasons maybe a lot of operators favor it. Another thing, all those trials compare two-stent versus provisional strategy. Well, you would ask me, is there a trial that compared one strategy to the other? There are a few. The most important, maybe modern one, is the DK crush 3, which compared DK crush to Culotte in distal left main bifurcation. And it showed that DK crush was superior on mains. DK crush was associated with lower MI and lower TVR especially. However, the issue with that trial, it was criticized, and there is a question mark about the Culotte technique that was used. Maybe the operator were very good in DK crush, maybe they were not as good in using the Culotte technique. The bottom line here is you can use any of those three as long as you're very good at it and you know how to follow the optimization steps carefully, and you're able to rewire and do final kisses. That's kind of the message I want to get. Okay. With that said, I'm going to start by describing the techniques. I will start by describing the crush, which is my preferred technique. And I will start with the traditional crush. Then I will describe the DK crush and the differences between the two. So this is the traditional crush, okay? And I will describe the traditional miniCrush, which is what we use currently. So here's how we start. The traditional crush, you need definitely 7 French guide because you will be positioning side by side simultaneously 2 stents. For that reason, you need 7 French guide. So the way it started, the crush, first you double wire main branch and side branch. You balloon and prep them well. You can use lithotripsy balloon if you have to. So you prep them very well. Then you position 2 stents. You position 1 stent in the side branch, sized 1:1 to the side branch caliber, and you position 1 stent in the main branch, sized 1:1 to the distal main vessel. And you deploy them sequentially. So first you deploy the side branch stent. You make it hang as you're deploying it and position it. You make it hang, that lower arm of it, you make it hang out about 2 to 3 millimeters. And you make sure the upper arm, which is the more difficult to cover, is definitely covered. So 2 to 3 millimeter hang out, you deploy it. And after you deploy it, you remove your wire and balloon, and you crush it with that stent that has been stationed and waiting in the main branch, in the main vessel. Okay. So after you do that, so I would tell you that I like to take out the wire and balloon before I crush that stent. The reason is that in the crush, there is never a reason, I think, to ever jail a wire between stents. We jail wire when we're not stenting a side branch, but there is never a reason to jail wire between stents. So I take the wire and balloon out and I crush that side branch stent with the main branch stent. After that, the main step here becomes to rewire that side branch through that crush stent. And you have at least 2 layers of stents here, 3 layers close to the upper arm of the side branch. So you have to cross those and do your final kissing balloon inflation. And that's the most difficult, by far the most difficult step of this whole procedure. So how do you rewire the side branch? It is key before rewiring to do the POT, proximal optimization technique of the proximal main vessel stent, of the proximal portion of the main vessel stent. So you pot with a larger and shorter balloon. Like I explained last time, this balloon of the pot should be sized to the proximal vessel, which should be equal to the summation, to 2/3 of the summation of distal main vessel plus side branch. So you put a larger, let's say the main vessel stent was 3 millimeter, you're putting here a 3.75 millimeter balloon to do a pot. And remember, in the pot, your balloon should not extend beyond that carina point. It should land around the side branch ostium, but does not extend to that carina point to avoid pushing the carina, and in this case, distorting the stent and the side branch itself. So you do pot, that will oppose those stent struts better, and then you try to recross and rewire it. And assuming you rewire it, then now you will do your final kissing balloon inflation. This time, the final kissing balloon, the balloons are sized to the distal vessels, to the side branch and to the distal main vessel. The summation of those two balloons, 2/3 of their summation will be equal to the size of the main vessel. So you don't have to think too much, just size it to your distal vessel, probably size it to that stent, or maybe a little bigger if you think you are a little undersized here, plus size that balloon to that side branch, and your summation will automatically be equal to that main vessel, because the summation of the two balloons will be 2/3 of their true mathematical summation. Okay, so you do that kissing balloon inflation, and it is recommended nowadays to do a final pot. Like we did here, we do a final pot. A lot of operators don't do that final pot, but it is recommended in all recent papers, including the European Bifurcation Club. It's important for that pot to be, again, well positioned. If you do your pot after your final kiss and you position that pot balloon, you make it extend beyond the carina, you're going to distort whatever the final kiss has achieved. Okay, you're going to distort that side branch stent. So your pot has to be very properly positioned. If you cannot properly position, it's probably better not to do that final pot. And it's better to use a stent boost technique to properly position it. Okay. Here there are some additional tips I want to describe. One, the final kissing balloon inflation is meant to properly expand that side branch stent at the very ostium. Two, to eliminate all the stent distortion and the overlying metal distortion that occurs at that side branch ostium. The catch of the final kissing balloon inflation is that it can create, when you put two balloons side by side, their summation here will be equal to the main vessel, but it's not going to be a circle, it's going to be an ellipse. So it can create an elliptical eccentric distortion of the proximal main vessel. And that's the reason why pot has been recommended. The same miniCrush that I just described, the traditional single kiss miniCrush, can be performed using a 6 French guide with a slight modification. It's what we call the sequential single kiss miniCrush. So instead of positioning the two stents simultaneously, which requires 7 French guide, you position a stent in the side branch and a balloon in the main branch. You deploy the side branch stent, then you crush it with a main branch balloon. Then after that, you take your main branch balloon and you position a main branch stent sized to the distal vessel. And then you recrush that side branch stent with the main branch stent. So again, You crush the stent, the side branch stent, with a balloon instead of stent, so you can fit them in a 6 French guide. Then you re-advance your stent and crush that side branch again with a stent. Then you follow the same steps: the pot, the rewiring, the double kiss, repot. Okay? The idea is that you can position inside a 6 French a simultaneous stent balloon if they are 3 millimeters or less. Keep that in mind. It will not work. Even that sequential miniCrush is not going to work probably in most left mains. You have to have both those tools 3 millimeters or less. Okay? It may work in left main if your LAD and left circ are 3 millimeters or less. Okay? This is different from DK crush, and I will explain in a little bit. This is still sequential, regular, traditional crush. Okay? The same, by the way, when you use tap. In tap, that I explained last time, you simultaneously position stent balloon. You deploy stent on the side branch while a balloon is positioned in the main branch, and tap can be done for that reason through a 6 French guide. Okay? So only the traditional miniCrush that is not sequential requires a 7 French guide. I mentioned miniCrush. So there are 3 types of traditional single kiss crush. That same technique I described here, the traditional single kiss SK crush, I described the miniCrush, but actually it's the same technique for 2 other ones. Those are the 3 subtypes of traditional single kiss crush. The difference between them is how much you make the side branch stent hang in the main vessel. miniCrush means you make it hang 2-3 millimeters, the lower arm, so that you're guaranteed that the upper arm of the side branch, the one difficult to cover, is covered. Okay? The classic crush that was described by Colombo initially had much more stent hanging in the main vessel, and subsequently much more stent being crushed against the wall, against that upper arm of the side branch and main branch. Okay, so that led to more stent struts, meaning more metal, more difficulty recrossing, more mace and adverse events. So that's why we don't do that anymore. Nano crush means you barely hang that stent, so much so that you just enough cover the upper arm of that side branch, and you make it the lower arm hang only about 0.5 to 1 millimeter. It's not the preferred technique simply because in order to nail it that perfectly, one, the angle of that side branch has to be close to 90 degrees so that you can hang it only 1 millimeter and still cover the upper arm. 2, really, you have to be really good in nailing it and not missing it. There is a good chance you'll end up, if you try to barely hang it, you'll end up missing that side branch ostium here, okay, which defies the purpose of the whole procedure. So that's why nano crush is not widely used. This is the most common crush technique, okay, traditional single crush technique. And this makes it easy to rewire, much easier in comparison to the classic crush. So overall advantage of that traditional miniCrush compared to other 2-stent strategy like Culotte, it's the stenting of both branches, side branch and main branch, is easy. And notice that we deployed both stents without having to rewire anything. So you're guaranteed you're going to be able to stent both branches. The issue becomes when you want to rewire and do your final kiss, but you've already deployed both your stents. Okay. The problem with it, though, is that you have to rewire through a difficult carina with 2 to 3 layers of metal. And if you don't rewire, you will have a lot of adverse events, as I will describe. But the beauty of it is that you already have your 2 stents up front. Very easy to deploy your 2 stents. You're positioning them already up front. Okay. The rewiring with the traditional classic crush, single kiss classic crush, can fail in 5 to 25% of the cases. And why is that rewiring? I keep talking about in every slide. Why is that rewiring important? If you're unable to rewire and do a final kiss, you have much higher risk of MI and target lesion revascularization. The explanation is the kiss, as I explained, Without the kiss, the side branch will be distorted, irregular. You will have pieces of metal hanging irregularly in that area, and it will be expanded at the very ostium. In Cactus trial with the classic crush, inability to do final kiss was associated with much higher risk of MI. Look at that, over 4 times higher risk of MI, much higher risk of TLR, much higher risk of stent thrombosis, 6 times higher risk of stent thrombosis. That's why final kiss is so important. Rewiring is so important. And that's why I even avoid, like I said, rewiring. I avoid two-stent strategy if I don't think I can rewire. And, you know, when do I think that rewiring will be difficult? As I take that into account as I'm planning my strategy, provisional versus two-stent. And as I said, it's better to do provisional than to do a suboptimal two-stent strategy without rewiring and kissing. It is easier to rewire in proximal disease. Imagine left main. Why? You're next to the guide. You have one-to-one torque control over your wire. So you really have, you're able to rewire that side branch with much more control. Also, your vessels are potentially larger. This is much more difficult if you're doing bifurcation here, past in left circumflex OM, past tortuosity, especially heavily calcified tortuosity, smaller vessels. You have much less wire control, okay? In those cases, one, you have to think twice about doing two-stent strategy. Two, you very much have to consider the double lumen catheter that I described last time that allows you to point your wire with some support, with some bulk support in the main branch, point your wire into the side branch, okay? And also in those cases, you may end up, in order to rewire the side branch, you may end up having to use a polymer wire. Generally speaking, as I described last time in the provisional approach, it applies to the two-stent strategy. I like to rewire with a non-polymer wire, such as a BMW wire. The reason is BMW wire is less likely to go behind the stent struts. And if it does go, you will feel it. You will feel a scratch of that wire as you're advancing it, or especially as you're pulling it back. So a lot of time as I'm rewiring, I pull, after I get here, I pull my wire a little bit and I feel, do I feel a scratch? A scratch tells me I'm going behind the struts. With a polymer wire, it's more easy to slip behind the struts and you don't have that tactile feedback. So I prefer not to use a polymer wire. The problem when you have to rewire distally, you may end up having to use a polymer wire across all those tortuosity. And that, again, reduces the chance of a proper rewiring. One thing I want to comment on, a lot of operators and papers say that in order to rewire your side branch, and I'm talking in general here, provisional and two-stent strategy, they take that main branch stent that has been stationed throughout your procedure and they pull it out and they try to rewire the side branch with it, thinking that, okay, I'm guaranteed my main branch stent is definitely not behind the struts, so I'm going to pull it and rewire. I totally disagree with this approach and I hate it. I think you should bring another wire, shape it properly, non-polymer wire, and aim toward that side branch. I would never want to lose access to my main branch, because what happens when you pull that main branch wire out, well, there is a chance when you try to rewire the main branch, your wire now will go behind the stent struts in the main branch. Now you lose proper wire access of your main branch. I never like to compromise my main branch, so I disagree with this technique. Second, when you pull it and try to rewire, most of the issues occur around this area and you'll end up pulling it a little too much and your wire may still go behind the stent struts. So I don't like it. So anyway, considering how difficult it can be to rewire the side branch through stent struts, this is where the idea of DK crush came. The main advantage of double kiss crush over the single crush that I described is the ability to rewire the side branch and do final kissing inflation after double stenting, even through 3 stent layers. In the DK crush trials, this was successful in 100% of the DK crush procedure versus only 75 to 90% with the classic crush. However, they used the classic crush in those trials as a comparator arm. other studies have shown that actually rewiring with a single kiss crush is highly successful if you just use the miniCrush. So just using the miniCrush, traditional miniCrush, in some papers, it's 98% success if you're really not having too much metal hanging here. Anyway, the decay crush is more successful rewiring. The catch, though, as you will see, it's more successful rewiring, but you have to rewire it twice instead of once with a single kiss crush. So it's more successful rewiring, but it's more rewiring and more steps. And I'll show you how the decay crush is done. So again, you wire both branches. And by the way, decay crush can be done through a 6 French because you're never positioning 2 stents at one time simultaneously. So it can be done through a 6 French guide if both areas are 3 millimeters or less. Anyway, the way it starts, you put a side branch stent and you put a main branch balloon. You deploy your side branch stent and you crush it with a balloon. Okay? So normally with the miniCrush, the traditional miniCrush I described, you go from those directly to crushing the side branch stent. Meaning you position your side branch and you position next to it a balloon or a stent. You crush that side branch stent. Then if you did it sequentially, you crush it again with a main branch stent. So you go directly from this side branch stent to crushing it with a main branch stent, or from this to number 4. That's the traditional one. The decay crush, what you do, you crush your side branch stent with a main branch balloon. Then instead of immediately deploying your main branch stent, you actually do another step. You rewire at this point, you rewire the side branch stent. You do a kissing balloon inflation. Then, and this is the important step, you rewire and do kissing balloon inflation. The point of that is that to open that side branch stent ostium and to mesh those wire struts to make them flat and well opposed at the ostium, so that when you eventually want to do your second and final rewiring, it's easier. You have less metals hanging. So again, you're adding another step. After you crush your stent with a balloon, you're rewiring with a non-polymer wire. You're doing a kissing balloon inflation to open that area. Then you take both your balloon and wire out. As I said, we always with crush, you never have to jail wire. So you take those out, you crush the side branch stent with a main vessel stent size to the distal main vessel. Then you do the same steps as I did with a regular crush. You do a pot, then you rewire, same step, same thing as a single crush. The difference here, as you rewire, that stent has been properly and better expanded at the ostium by that additional step, by that first kiss that you added. So you're more likely to be able to wire it properly with that kiss and with the pot. So you rewire it, then you do another final kiss, again, balloon size to the distal vessels. Then you do the final pot that I explained. Okay. I want to add a couple of tips to that technique. So that's really the only additional. Number 3 is the only additional step to the traditional crush. Again, it adds one extra rewiring, but it makes the second and final rewiring easier. And according to the decay crush investigators, you have a high success rate. And that has been also my experience. I have higher success wiring using this than doing the traditional crush. Although, again, probably with miniCrush, you're achieving also a high level of rewiring, even if you skip that step. Okay. A couple of additional tips. When you're crushing the stent with a balloon, some operators put a long balloon like this. So they crush the stent with a long balloon. That is fine, but that's not the best way, because when you're crushing with a long main branch balloon, you're sizing it to distally, so it's a small. The ideal is to use a small balloon to crush. Use a small balloon and large balloon to crush that side branch stent. It's like a pot. It's basically your crush is a pot. So your first balloon crush is also a pot crush. This way you oppose that stent well so that you're able to rewire it. So when you're doing DK crush, your first balloon crush is also a pot crush that opposes the stent well and allows you to rewire it. You can do it sequentially. I mean, you can do, employ a long balloon here to crush it, then use a short balloon to do a pot of that stent. So as a summary of those techniques, or not as a summary, as a key ideas I want you to remember, whenever you position a balloon or a stent in the main branch that extends to the distal main branch, you have to size that balloon or stent to the distal main branch. Do not oversize. And each time you size a stent to the distal main branch, you have to always pot, whether in provisional or in any two-stent strategy. Always a main vessel stent extending to the distal main vessel should receive a pot. Each time a stent is deployed in the side branch in any technique, you have to rewire and do final kissing inflation. You often have that sequence in any of the techniques: pot, rewire, kiss, repot. So pot, rewire, after you wire, kiss, and pot. You kind of see that. You almost memorize it. Pot, rewire, kiss, repot. Okay? When doing a kiss, that's an important tip here. How do I do the kiss? It's nowadays you should do the kiss in a sequential fashion. So kiss means you inflate both balloons sized properly to the distal vessels, as I said, to 10-12 atmosphere. But a better kiss is to inflate each balloon, especially in this part, when doing kiss inside the stents. Inflate each balloon at high pressure sequentially. So inflate this balloon at 16, 18, even 20 atmosphere if you need, as much as you need to properly expand that side branch ostium. Then deploy this balloon as high pressure to properly expand your stent, then do your kiss. This is what we call sequential kiss. Very important to expand your stent. Very important in that when you do the crush in that part, to properly expand the ostium and be able to rewire. Okay, so do sequential kiss. High pressure in each branch, then simultaneous kiss at 10 to 12 atmosphere. Another important tip. I mentioned when I talked about provisional last talk, when you're rewiring, oftentimes you have to take what you get. As long as you're not going behind the struts, take it. But a lot of operators prefer a particular type of wire recrossing. In a provisional, I described that you have to try to go through the distal stent struts at the carina. The idea is it's more difficult to cover the upper arm of the side branch. So you have to go through the distal struts, deploy a balloon, and that will push those struts to the upper arm of the side branch and create a scaffolding of that side branch and make it easy to put a T-stent if you like. Okay, you have less need to hang that T-stent in the main branch. So you go through the distal stent struts. However, and that applies to the tap, to provisional, to tap, and to culotte technique, distal recrossing. Crush, on the other hand, you want to cross in the center or close to proximal. The idea with crush is different. If you rewire distal in crush, you already have a stent in the side branch in the crush, and you already have heavy amount of metal at the upper arm of the side branch. You have 3 layers of stent in the upper arm of the side branch. So if you go distally and balloon, well, you'll be pushing more stent struts towards that upper arm that's already heavy in superimposed, disrupted layers of metal. So you don't want to go distally. Another thing, if you go distally, you may go behind the stent struts and malappose the stent. So you balloon here, you malappose your stent. Okay, so you try to go proximally or better centrally, non-distally. That's the idea. When you go non-distally, this is when you create a perfect opening of the side branch ostium. So that's the better way of doing it. Okay, but again, you know, oftentimes you have to take what you get. Another important idea, I tell fellows that all the time, in bifurcation stenting in general, and specifically in the crush and culotte techniques, Restenosis is most often at the ostium of the side branch, particularly at the ostium of the left circumflex in left main stenting. That is the Achilles heel of left main stenting. You get poor stent expansion in a very high recoil ostial area. You get distorted, irregular stent struts. You may get stent fracture as well. So how to prevent that? It's very important to do those 4 ideas. One, you need to properly prepare your side branch before you put any stents, using cutting balloon, lithotripsy balloon. We're lucky today we have advanced technology, including lithotripsy balloon in calcified vessels. High pressure expansion as well, high pressure pre-dilatation as well. So that's important. 2, that stent that you deploy in the side branch, before you crush it, even before you crush it, you have to expand it well. And that's why it's recommended nowadays, and I didn't want to tell you all the ideas at once, you don't just deploy the side branch stent. Before you crush it in DK or single kiss crush, pull that balloon backward a little bit and go higher pressure. Let's say you deploy it at 10 atmosphere, 12 atmosphere, well, pull it back and inflate it at 18 atmosphere. Ensure proper side branch expansion. This is before you even kiss it again at high pressure. That will help with rewiring and will further help with the stent expansion. Okay. So good stent expansion even before crushing it. Good stent expansion, number 3, good stent expansion even after crushing it. In each of your final kissing inflation, do that sequential high pressure final kissing inflation. And the 4th and very important thing is IVUS. Ensure proper ostial left circumflex expansion. As I mentioned in OCT and IVUS talks, that stent should be expanded to over 80% of the reference left circumflex diameter, or at least, if you remember, absolute number 6 millimeters square. If your left circumflex stent is less than 6 millimeters square, you're going to have a high risk of restenosis. That's very difficult to treat. I hope everybody understood those ideas. I want to go over a case to illustrate. I have a lot of cases. I won't go over all of them, but I'll give you a case. So this is an 85-year-old man, EF 30%, anterior akinesis, heart failure with reduced EF. He has distal left main, severe distal left main disease with an ostial left circumflex 75%. All of this area is heavily calcified. The left circumflex disease has a heavy burden with actually multiple bifurcation, and that usually does push you toward doing two-stent strategy. Of course, you pick one of the bifurcation, one of the side branches, and you go for it and you do two-stent strategy. So multiple bifurcation, heavy calcium, lung disease. Here is what we did here. So I'll go over the steps. First, we did proper preparation. We did sequential lithotripsy balloon, 3 by 12 millimeter balloons. We used impella support in this case, by the way. Second, we started with our DK crush. So I did DK crush in this case. That was a case I did 2 days ago. So I positioned the stent in the left circumflex, 3.5 by 16 millimeter, while having a short 4.5 by 8 millimeter station in the LAD. This balloon, the goal of this balloon is to crush my stent. So I deploy the left circumflex stent while positioning this balloon a little bit distally. I don't want that balloon to be proximal and end up missing the expanded left circumflex stent and being stuck there and not be able to be advanced. So I have to position it past where I will expand my stent, okay, or at least around it, okay? So you position it here or a little past that left circumflex stent. So I deploy the left circumflex stent at 12 atmosphere. Then I pull that balloon in the left circumflex and I deploy at higher pressure to inflate that ostium well at 16, 18 atmosphere. Then I take my wire and balloon from a circumflex out. As I said, we never have to crush a wire or jail a wire in a crush technique. So I take them out. Then I crush the stent, which also serves as a pot, with a short balloon sized to the left main. I crushed it with a 4.5 by 8 millimeter balloon proximal to the carina at 16 atmosphere. This is the pot crush. Then I rewired the left circumflex with a BMW non-polymer wire. And here I shaped it properly using a sharp bend, okay? And you can see here. So watch, that wire it went in, but it went through a distal strut, if you watch carefully. Watch it, look at it, and it went through a distal strut. We did not like it because I believed I could rewire through a proximal strut. So we took it out and we rewire again through a proximal strut. So if you can wire through a proximal strut, as I explained, in crush and DK crush, try to wire through a proximal strut. In the other ones, try to wire through a distal strut. So I rewired with the BMW. Here we went proximal. It doesn't have to be, proximal. Actually, you don't want it to be very proximal. The idea is to be central or at least non-distal. So here we rewire through a non-distal central strut. And notice, I do want to give you an idea I mentioned last week. Notice how that wire is shaped. I always love that shape. Look at it. So two bends, a proximal and distal here. The proximal band, I'll give you a tip of how to shape it. That proximal band, the length of it corresponds to the diameter of the left main. So the larger that left main, the longer this should be. The sharpness of it corresponds to the sharpness of the SAR. So the sharper the SAR, the more sharp that angle should be. You got me? And I put that distal band in order to keep me centered. Okay, so I don't hug the wall of the circ, but I rather stay centered in the circ and centered over the stent of that circ. So after I've crushed the stent, we rewired, we did sequential kiss, okay, including sequential high pressure kiss, sizing the balloon to the distal vessels. Then I took the left circumflex wire balloon out. We deployed the stent in the LAD to left main, size to the LAD 3.5 millimeter. This is this step. Then we did part of that with a 4.5 millimeter balloon, non-compliant balloon. Then we rewired that circumflex for the second time with a BMW wire, again, non-distal strut. So here we're reaching that stage of pot, rewire, kiss, sequentially high pressure, then repot proximally. Again, that final repot, you have to be very careful. You do not want to extend beyond the carina. This is my circ stent. Look at that dot of the balloon. You make it land somewhere in the middle of the left circumflex awesome. You do not extend it beyond. Otherwise, you'll create a mess. You'll destroy whatever you did in your final kiss. Okay? And this is the final result. Very good, I think, stent expansion across the circ and the left main. I won't talk about the culotte technique. So before I talk about the culotte technique, just imagine how the culotte looks like first. Culotte, the concept of culotte consists of having one stent extending from the main branch proximally distally and having another stent from the main branch to the side branch. Both those stents are overlap proximally. You have two circumference in that main branch. You have two full layers of stent struts in the proximal main vessel, okay? One of the stents go in the side branch, another one goes into the main branch. No need to fully overlap proximally. Some people think you need to fully overlap. Actually, it's advised to not fully overlap, meaning make your side branch stent short. Create as little overlap as you can, as few millimeters as you can. Less metal overlap, better, okay? This is what I would call the mini culotte. Less culotte, less overlap. Here are the steps of the culotte. So first you double wire, then you stent your side branch, and culotte can always be done through a 6 French because you never have simultaneously two stents position. Actually, you never have at any time a stent and balloon simultaneously. So culotte can always be done through 6 French, even when you're using devices over 3 millimeter in caliber. So it can always be done in 6 French, and that's a major advantage of this technique, if that's your only option, 6 French. Anyway, so you double wire, then you deploy your side branch stent, and you deploy it all the way, you want it to be opposed to the main branch vessel. However, it's not going to be opposed initially because you're undersized proximally. So you deploy your side branch stent, you pot the proximal portion while jailing the wire, as they did here. Then you rewire the main branch while having that wire here in the main branch jailed and protecting it. After you rewire, then you do balloon inflation of the stent, and preferably do a kissing balloon inflation. And after doing that, then you advance your main branch stent. So you start to do the side branch stent into the main branch, then you do the main branch stenting. And in this case, you should, as you're doing the main branch stent, you should take out the side branch wire. Okay, you don't want to jail that side branch wire through two layers of stent. So after doing that, then you do the pot, then you rewire again, then you do a final kiss and repot. Okay, this will be the sequence here: pot, rewire, kiss, repot. Okay. Now, what's the catch of this? There are a couple of problems. One, you're having to rewire twice systematically, unlike a crush where, at least in single kiss crush, you don't have to rewire twice. So you're having to rewire the main branch. Then after you deploy the main branch stent, you have to rewire the side branch through potentially two layers of stents. So that's one caveat of this. Two, and the biggest caveat to me, is that you're having to rewire the main branch. At least on the crush, you never have to rewire the main branch. It's always rewiring the side branch. Okay, you're rewiring the side branch twice, but it's always rewiring the side branch. If you fail, you have an increased risk of MI in the side branch and TVR. But your main branch is always controlled. The culotte, that's my concern. At one point, you're jailing the main branch. When you're deploying the stent here, you're jailing your main branch and you're having to rewire the main branch. Well, imagine if in this step, imagine the main branch occludes. It's true there is a wire, but that's not enough. Imagine it becomes 100% occluded. Imagine you're doing left main. This is the LAD. Well, now you have 100% occlusion of the LAD, and you're trying to rewire 100% LAD occlusion with the patient having massive anterior infarct on the table. So you're losing control of your most important branch in this procedure. And if you fail to rewire, you're having an immediate catastrophe, not just a long-term catastrophe. That's the biggest catch of it. Now, of course, you can do culotte in what we call reverse fashion, meaning, okay, well, why do I have to deploy my side branch stent first? And yes, you can do that. And that's one way of doing it, is to deploy your main branch stent first. Let's imagine this is the main branch, you deploy it first, then you deploy the side branch stent later. This way, you never lose access to your main branch, and you're never risking having to rewire a non-stented main branch. Okay, you can do it in this case. The only problem is that, you know, it will be harder to rewire a side branch than to rewire a main branch when you're doing the rewiring in the opposite sequence. Okay. Some people used to say that another caveat of culotte is that, well, the main branch is much bigger, is bigger than the side branch. And in order to do culotte, both those should be of equal size. That's not necessarily true, because as it is with crush, I showed you that we can expand stents to beyond their nominal diameters. And we have to expand actually even the distal main branch stent in the proximal area. So you always have to expand and make them match the proximal vessel. The proximal vessel is never equal to neither one of those. So size mismatch is not a good argument against culotte unless you have a huge size mismatch. Like the side branch is 2.25 and the main branch is 4. Then you cannot expand a 2.25 stent to 4. There is a limit, and there are charts that show you that there is a limit to how much you can expand the stent. Usually it's in the range of 1 millimeters. So only if there's a huge mismatch between the branches, culotte will not apply. But in general, mismatch is not an argument against culotte. Okay. For the next few minutes here, I want to go quickly over other techniques. So the tap technique, I explained it last time, the provisional tap, it can be used as a planned two-stent strategy. And you can do it exactly as you do the provisional tap, meaning you double wire, you stent the main branch, you pot, you rewire that side branch, and then you deploy your stent in the side branch while having a balloon in the main branch, and you do that simultaneous stent balloon inflation at the end. Okay, so you can do it exactly like this with excellent positioning and having a slight neocarina hanging in the main vessel. So you can do it exactly this way as a planned fashion. You can also do it in a planned fashion. You can do it like you do the standard culotte. Basically, you start your T-stent by stenting in the side branch, then you pot that side branch, then you recross in the main branch. But then instead of doing culotte of that main branch, what you do, you position the main branch stent in a T fashion, okay, with a simultaneous stent balloon, with a neocarina like this. So that's one way of doing plant tap. It's what's called a reverse tap. But you can do plant tap in a regular fashion. That's what I prefer, starting with the main branch, or you can do it in a reverse fashion, starting in the side branch, as with the standard culotte. I don't like that technique because, again, I don't like to ever lose control of my main branch. I don't like to ever jail my main branch. Okay, so I don't like that technique, although I've done it, but I don't like it. That's an illustration of here of how they did tap in the left main, reverse tap, starting in the left circumflex, then rewiring the LAD and putting the tap stent from the LAD into the distal left main, creating a neocarina in the distal left main. That technique was commonly done in the Excel trial. So it's not a bad technique, tap as a planned technique. I will need a few more minutes and I will describe very quickly what you asked about in the chat box, which is this, the simultaneous kissing stent. The simultaneous kissing stent is the easiest stent technique, but it's also the worst and the one that we should not regularly use. It's only used in emergency. Basically, it's very easy. You double wire and you double balloon. Eventually, you deploy both your stents simultaneously, and you end up with this, what I describe as a double barrel. Okay, you have in the middle of the vessel, you have a piece of overlapping stents. Okay, this should not be done. The idea of this is it's done in emergency. Let's say you dissected the left main, or you have left main MI with occluded left main. You want something quickly. Even in those cases, usually you try to obtain a good result with balloon, then do culotte or miniCrush or tap quietly. But if balloon is not stabilizing the patient and the occlusion, this is a case where you have to do something quickly, do your double kissing stent. Okay. A modification of that is used is a simultaneous kissing stent that is without main branch disease. So imagine you don't have proximal main branch disease. So you have what you call 0-1-1. So you can do simultaneous kissing stent without any carina in the main vessel. And this is what we call the V stent. It is applicable to a small amount of patients, about 2 to 5% of patients in left main trials, 2 to 5%. So you can use that. And in reality, it's not going to be perfect. You will have a small carina in the left main with a probably small double barrel, but it's going to be small. So when you have isolated ostia of LAD and left main, you can do that simultaneous kiss V stent in this case with no or minimal carina in the left main. So this is for all the two stents technique. There is one idea I want to address. It's a general idea that I get asked about a lot by fellows about jailing wires that is used in provisional stenting and is used in culotte and tap. We don't jail wires, as I showed you in crush, but we jail wires in every other technique, including most commonly provisional. The big question I always get asked, can you jail a polymer wire? Polymer wire has the advantage actually of easier retrieval and probably less risk of fracture because it's a slippery wire, and probably less risk of sucking the guide when you're pulling it out. So it has a lot of advantage compared to a regular wire, okay? There is a concern that when you're pulling a polymer wire, even though it's less likely to fracture macroscopically and less likely to give you macroscopic troubles, there is a risk of shedding and microembolizing the coating material in the myocardium. And this has been shown in a paper published in Circulation, I believe, a few years back, in an autopsy study of patients who received polymer wire procedures. But the clinical implication of that shedding of micro polymer is not known. So again, a lot of advantages, one theoretical disadvantage. But the bottom line is one study that put it to rest and told me that, yes, you can jail polymer wires. And since then, I've been doing it. So this is a study in JACC intervention in 2016. They actually randomized patients to jailing a wire, to jailing a polymer wire or jailing a standard non-polymer wire. Polymer wire is like Whisper, Pilot 50, Choice PT, Floppy. Non-polymer wire is like BMW Pro Water, Samurai. So and in that study, the interesting thing they found, and what they did after jailing the wire, they took it out and they analyzed it on the microscope. And what they found, actually, the non-polymer wire have much more risk of wire damage, okay? 55% of patients had wire damage when you jail their wire in the case of non-polymer wire. Almost none of the polymer wire patients had wire damage. This is despite the fact that they went to high pressure. Okay, so that study put it to rest that yes, you can jail polymer wire. It may actually be better to jail polymer wire, less risk of stent damage and stent fracture. And you can even jail polymer wire, unlike the old teaching, even with relatively higher pressure. They went up to, up to 17 atmosphere here. So you can jail polymer wire even up to high pressure. I want to show another case of decay crush for illustration. This was done by one of my colleagues in Iowa. This is a case of severe in-stent restenosis of the LAD, and it is a true bifurcation with severe disease involving a large diagonal branch. The disease is about 10 millimeter long with heavy plaque burden extending further distally into the diagonal and into its branches. Here you have two options. You can perform a provisional strategy with a pre-dilatation of that diagonal and a provisional tap stent of that diagonal. The angle is favorable for that. Or you can proceed with two-stent strategy. I would be concerned about being able to rewire that diagonal, especially rewiring it twice for decay crush or even once for miniCrush, especially that there is already one old layer of stent here. And for that reason, I may prefer provisional approach with tap stenting if needed. As I said, I take into account how difficult rewiring would be when I choose to do two stents, as a lack of rewiring to final kiss leads to dire consequences. The operator here decided to proceed with decay crush. They double wired and they prepped both the LED and diagonal properly with pre-dilatation. Then they positioned a diagonal stent and an LED balloon. The diagonal stent should be barely hanging in the LED, less than in this picture, probably just like I said, about 2 millimeters. So the diagonal stent was deployed, then it was crushed by an LED balloon, the stationed LED balloon. A couple of tips here. After you deploy the diagonal stent and before you crush it, it's best to pull back that balloon, as I explained, and do a higher pressure inflation of the ostium of that side branch, just to get better expansion of that difficult to expand area. That's one. Two, in regard to the balloon used for crush, you can do that, a long balloon sized to distally, but my preference, as I explained, is to do a short balloon and larger balloon sized to the proximal vessel, so much that the crushing of the stent will also serve as a pot. Okay, if you use a long balloon sized small distally, redo another balloon that would serve as a pot, so that you oppose that crush area very well so that you can rewire it. So after doing that and after crushing the stent, now it's time to, and this is the picture that shows you the crushing of the stent. Now it's time to rewire that diagonal. So then you rewire that diagonal, and then you do a kissing balloon. This time the kissing balloon, the balloon of the main branch, the LAD, would be sized to the distal vessel. Okay. So after doing the kissing balloon, now you're ready to position a stent across the LAD and recrush that diagonal stent with an LAD stent. And that's what they did. They positioned stent across the LAD. Obviously, you remove the diagonal wire at this point. As I said, there is never a reason to jail a wire between two stents. So you take that wire out, you deploy the LAD stent, and that LED stent is sized to the distal vessel. They use here a 3 millimeter stent. Then after doing that, you have to be ready to rewire that diagonal for the second time and for the second kissing balloon. But before that, remember, after each deployment sized to the distal vessel and before rewiring, you always do a pot, okay, proximally all the way to the ostium of the side branch. So they did pot of the LAD proximally with a 4 millimeter short balloon that does not and should not extend beyond or to the carina. Then after doing the pot, the diagonal was rewired again, and final kissing balloon inflation was done. This time the balloons are sized to the distal vessel, including to the distal LAD. We placed a 2 millimeter balloon in the side branch and 3 millimeter in the main branch, the summation being 2/3 of 5, which is 3.3 millimeter in the proximal vessel. And after doing this, it would be wise, like I suggested earlier, to do pot of the proximal vessel using something similar to that size, about 3.5 millimeter balloon pot, properly placed, not extending to the carina. One note here, the wire that was used to rewire that diagonal for the third time was just a BMW wire, a regular workhorse wire. And this was the final result.